So, good evening, everyone, and welcome to our June Journal Club. We are honored to have Dr. Earp here today, who is an assistant professor and research associate at the Human Performance Laboratory at the University of Connecticut. His interests include sports science, MSK injuries, recovery research, and many other topics. He is passionate about sharing what PM&R has to offer and is a resource that we are excited to learn from today. Welcome, Dr. Earp, and thank you for speaking to us.
Right. Yeah. Thanks so much for having me. So thanks so much for having me. So today I'm going to be talking about the article, "The Effects of Isometric Loading Intensity on Patellar Tendon Microvascular Response." I don't, um, you know, you've already been introduced to me, so I don't have much to say on that. I don't have any conflicts of interest in this area. The plan today is I'll talk about patellar tendon prevalence, treatment, physical therapy, tendon microvascular function, and how our lab is viewing that as a target for a therapeutic mechanism and a way that it interplays in with tendon recovery. And then that'll lead into the study that's being presented today. And since I'm assuming it's a journal club format, I was just going to go study design, results, discussion, and then very briefly talk about the studies we've done since and the studies we're planning to do in this line of research. So patellar tendinopathy is one of the most prevalent musculoskeletal injuries across the population. It's reported about 1.6 cases per 1,000 person years. As people become more physically active, that prevalence increases drastically. It's up to 6.9 cases per 1,000 person years in military populations. And by the time we get to athletes, you can see various numbers with prevalence like 18% being reported across all sports. In running sports, it's 12.5% in recreational runners, 23% in marathon runners, and by far the most prevalent sport is volleyball, with some reports going up to 50 and even over 75% prevalence. And that's one of the reasons it's commonly called jumper's knee, because of the prevalence in these jumping sports. The cost of patellar tendinopathy has a direct annual healthcare cost of between $990 and $1,675. And the estimated cost per quality of life ranges from $27,000 to $40,000, and that does include lost time from work, impaired work that can happen over the course of a lifetime. So as you probably know at this stage, the most common treatment for tendinopathy is physical therapy in the form of resistance exercise. You'll see things like the incline sled, slow heavy loading, or isometrics. In the bottom picture, you can see someone doing isometric on a physio ball. This with activity monitoring is the activity modifications is kind of the first stage of treatment, but it's often paired with other therapies, things like shockwave, ultrasound, tissue manipulation, and massage, pharmacologically with NSAIDs, corticosteroids, glycerol titrate patches, and even things like dry needling, scraping, and PRP injections. Even though we have all these different tools at our disposal, the success rate for tendinopathy is not that great. And this is one of the reasons that I found myself going into this line of research, and that about a half to a third of individuals who take part in tendinopathy rehab don't have successful rehabilitation. And as people have more severe symptoms, or they've had these symptoms for longer, or they're repeat, we see that the likelihood of success drastically drops off. And in these cases, a quarter of all cases do end up requiring surgery, and this does exponentially increase the healthcare cost and the time for recovery. And even in those cases where surgery is required, 43% report no change in symptoms after the surgery. So really, I see this as one of those areas that we can do better if we can refine the therapeutic interventions we have. And I'm not the only one who thinks this. You've probably seen a wide variety of different physical therapies being used to try to trigger adaptation, either in the prevention or in the recovery from tendinopathy. Even in the examples that we gave, you can find all three of these different examples being used commonly in rehabilitation practices. You can see isometrics. Some facilities focus on isometric, some on eccentric, some on eccentric and concentric. Here at UConn Health, we actually do more on the isometric side, even though, surprisingly, even though the literature looks like it points that way, that's really just because there's been more research on isometrics than these other ones. So we really don't know which are better, and there are some advantages to each one. Also on the rate of loading, we've seen big changes happening and are continuing to happen. We used to look at rapid landing and rapid loading to elicit tendon strain, and that sense flipped on its head, and then we were doing intentionally slow movements. We know with isometrics, slow isometric contractions are better because it avoids that viscoelastic binding of the tendon and allows greater strain. However, when you go to eccentric concentric movements like a squat, my research and others have shown that the opposite's actually true. That once you intentionally slow down, when you have a fixed moderate load, you actually use less force to move that load, so you actually will go through less tendon strain. And then even the probably the most recent thing that I've been seeing pop up is how we treat the progression with the traditional conservative approaches being kind of pushed to more of progressive loading and actually eliciting mild to slightly moderate pain to allow for faster progression and trying to essentially interrupt that maladaptation before it can take hold. And why don't we know the best treatment so far? Well, the clinical trials are limited. Clinical trials are very difficult to perform in this population. Even though it's very prevalent, the treatment effect that we're looking at, we're trying to optimize a treatment. So finding something that may only have a 10% higher success rate when you have such an individual variation, both from the patient and the injury, makes this a very difficult thing to study without very large clinical trials. There's also large and ever-changing number of treatments. I mentioned a handful, but these are happening in conjunction with other therapies. We typically don't do research where we withhold any treatment. So this becomes very difficult to figure out what's this added benefit of a conjunctive therapy with something else that's being done. And finally, we don't really have good standardized objective outcomes with tendinopathy. We don't have a biomarker that we can hold on to. Collagen and collagen turnover that you might think would be good is actually out-signaled by the bone. We're really looking at physical symptoms, pain, and dysfunction, all of which are kind of subjective measurements. So we don't have a really good anchoring measurement in here. The best that's being used right now is tendon stiffness, where disrupted tendons will lose their stiffness and integrity. So recovering that is ideal, but it's not something like strength where we just want more stiffness is always being better. You do get to a point where that stiffness actually becomes detrimental once again. So it becomes very difficult to use that as an outcome. So our lab and others in this field, we take more of a mechanistic approach. Our goal is to identify the mechanisms driving tendon adaptation and recovery, with the idea that we can use these to better design and refine our interventions for preventing or treating tendinopathy. I originally started my research focusing on tendon stress and strain. However, I actually found that some of the interventions I was giving to maximize tendon strain, like doing moderate load jumping training versus slow heavy training, we'd actually get more strain on the jumping training, but we wouldn't actually see any tendon adaptations. So from that, I've kind of shifted my focus that yes, tendon stress and strain are necessary to stimulate adaptation through mechanotransduction. But on the same side, now I'm starting to breach more into tendon functional blood flow. because I think that's really one of those key components that's kind of misunderstood, and that could help us help guide future intervention development. Now, this might be something you've seen in your textbooks before, how the vascular structure for the tendon is. Tendon has a fraction of the relative blood flow to the muscle it inserts, about 1/20th. This blood flow is essential for the tendon to maintain proper tissue turnover. It aids with recovery and remodeling. Is how we deliver those growth factors we'll want, things like IGF that can stimulate healing, collagen that can be a fundamental building block, and also how we remove those highly inflammatory cytokines and metabolites and damaged debris. So tendon blood flow is important, and we also know that areas with poor tendon vascularity are seeing less turnover and actually are higher risk for injury. So we think that there is a direct link between tendon, the avascularity of tendon and recovery and remodeling potential. Now, how the blood flow is supplied to the tendon, you have these parallel feeding arteries that have these mesoteins that branch into the tendon to cross over through that tendinous sheath, that epithelium. And that this is how we feed in, and also then with the vasculature coming out, how we extract out into the venous system. However, what's less talked about is how this is actually structured. If you look at the image on the right, you can see this is a electron microscopy image of a tendon from a mouse. And what you have is you have this non-fenestrated outside of the tendon. So that epithelium does not allow any fluid exchange. It creates this isolated barrier, just like the blood-brain barrier. This is called the tendon blood barrier because it has these, you have these non-permeable substance, and then you have these fenestrations, these tight junctions that allow for the reasons where these mesoteins can actually penetrate in and where you can have effective tendon blood flow. These are very tight junctions, so at rest they don't allow the movement of larger molecules. We go, the size range can vary, but usually it's around 10 kilodaltons to 100 kilodaltons that you're seeing. For things like IGF, that's around 7-fold larger than that. It's not getting through at rest. So to be able to deliver these growth factors, to be able to deliver collagen, to be able to remove these cytokines, we do need to actually facilitate that exchange of fluid. And this is how functional tendon blood flow presents itself. And as you might have expected, because of the topic, exercise is the main way that we know we can do this. So exercise creates a pressure differential where you develop pressure in there that can eject fluid out, and then you have a negative pressure, that osmotic pressure that facilitates blood coming back in. Exercise can also have a passive thermal effect. And when you do have that exercise, you increase the permeability of the tissue, and you also have a nitric oxide release. And this causes that vasodilation that allows more rapid flowing more rapid and free flowing blood into the tendon. Here's some images from a study by Kubo on this topic, where he had his participants do 5 sets of 10 reps, and I believe this was for the Achilles tendon. And you can see that the solid, open circles on the top is the tendon. For THB, which is our total blood flow, that the total blood flow didn't really change too much, but then after exercise, you can see this massive spike up. And this spike up is that post-exercise reaction that ends up being where we facilitate all those positive things that we're talking about. And this is also what we see with our anabolic response. When you have those androgens being released, you have the IGF being released. Those are very pulsatile in their nature. They occur with a rapid signaling post-exercise. And this increased blood flow does allow those to get into the tendon and effectively do what they need to do to start promoting that healing and that remodeling process. The same thing is seen if you just remove the physical loading and instead you just add a blood pressure cuff on. This is a reactive hyperemia where you can see you can artificially induce ischemia by pumping up a blood pressure cuff up to around 300 millimeters of mercury. And then if you hold that for 5 minutes and release it, you can see that the same thing will happen here, that you'll have this rapid influx of blood into the tendon. And that's the image on the bottom, that tendon being reperfused. The dot line is the tendon, the solid line is the muscle. And similarly, you also will see that you'll get to a hyperemic response where you actually can increase the oxygen saturation of the tendon as well. And once again, this is something we believe stimulates the tissue remodeling process. When you have damaged and disrupted tendon, making sure you have effective blood supply is one of the most important things that the body tries to do. We see that this is a normal, natural process of recurring from tendon damage during that proliferation phase, where you'll see that there will be that angiogenic signaling where you're trying to reestablish vascularity. So when you end up in a hypoxic state in the tendon, the body tries to rectify itself through that angiogenic signaling. And if you do have failed recovery where this doesn't occur, that same hyperemic response that I showed us in the last slide, if you have a case where that is not reestablished, you're more likely to see negative patient outcomes. Praxiteles, in a series of studies that were on this topic, looking at Achilles rupture post-surgical outcomes, found that the person on the top, or the people who had a display like the person on the top, where you had this post-occlusive reactive hyperemia, or you had this vascular function intact, they responded better to therapy in the long term than people who did not have this. And kind of the nice thing about the study is that they're looking short term after surgery, but then follow these individuals up for up to 6 months, looking at longer term outcomes. And they found that this was related to those outcomes several months down the line. And there is a lot of misconceptions around this because tendon and blood flow kind of get a bad rap, mainly because hypervascularization is a common sign of tendinopathy. About 30% of individuals with tendinopathy will come up with what we call a positive Doppler response, where you can put an ultrasound in color Doppler mode on the tendon, and you can physically see that the vascularity, which you normally can't see at rest. And this actually shows that there's increased vascularization within the tendon, and this is commonly seen with tendinopathy. However, this is also commonly seen without tendinopathy. Even though it's highly prevalent in tendinopathy, it is a part of the natural healing process. So it might just be a tendon that is vascularized through normal healing. It's not actually showing that you've had maladaptation or you reached that tendinopathy state. But it may indicate that you have that you have the sustained tendon hypoxia. Jarvin had a really interesting letter to the editor in the British Journal of Sports Medicine, one of the highest impact journals in the field of sports medicine. And he actually called for kind of a reevaluation of how we think about tendon vascularization. And he talked about how these formed neovessels that can occur are ineffective at delivering blood flow, but they're really just a bridge to trying to stabilizing and reestablishing normal oxygen saturation within the tendon, and that really what you're trying to do is avoid that sustained hypoxia. It's a pretty short article, only I think about 4 pages long. If you're interested in this topic, I do recommend looking up the Jarvin paper. And what we're trying to interrupt here is this negative cycle here that's in the bottom right, where you have tendon damage that leads to hypoxia. That hypoxia leads to neovascularization. And if you continue to load or you have maladaptation, that then leads to additional hypoxia, additional neovascularization, and impaired tendon function, and you have this negative sequence. And we hope that exercise can actually interrupt that. So if you give exercise, you can elicit this post-exercise hyperemic response, that we can interrupt that sustained hypoxia, we can reestablish, we can interrupt that angiogenic signaling, we can essentially stop the neovascularization and allow that tendon to properly heal. And that brings us to the purpose of the current study. So the presented study was the first in this line of research that we wanted to compare patellar tendon microvascular function to isometric or microvascular flow to isometric loading with 3 different intensities, 25, 50, and 75% of maximum, and we did isometric maximum. Our hypothesis was that patellar tendon total hemoglobin, which is our surrogate measure for blood flow, and oxygen content, which is HbO2, will increase with tendon loading. And we hypothesize that you'd see greater response at 50% and greater response at 75%. For this study, it was a relatively small cohort, 13 physically active individuals between 18 and 35, both males and females, no history of knee or tendon injuries. Most were recreational athletes. We did end up controlling for things like hydration, using urine-specific gravity, physical activity 3 days prior because we wanted to make sure the tendons were non-damaged coming in. They also avoided NSAIDs, depressants, and for 1 day prior, and any stimulants for 12 hours prior. For our study design, it was a within subject repeated measure. So all 13 individuals completed all 3 interventions, but they did that across 2 visits. In the first visit, we used this as our baseline testing. We obtained ultrasound imaging. We did a strength assessment where we got their maximal voluntary isometric contraction, the MVIC. You'll keep seeing pop up. That's in our field how we talk about strength for this isometric knee extension. This was a 5-second ramp MVIC, so it was how much they could hold over a 5-second duration, and we took the peak of that. And then after we got their maximal value, we then calculated out what 25, 50, and 75% of that was, and we had them practice doing submaximal contractions up to those intensities, and we gave them biofeedback during. So kind of like the picture on the bottom right here, we had them build up as quickly as they could or within 1 second, hold that for 5 seconds, and then relax. And they did this 3 times at each load. They had that force trace in front of them while they're on the dynamometer. So they were watching that. We were giving verbal feedback, and then we discussed it afterwards. So we had this continuous feedback, and this was really important because doing submaximal isometric contractions is kind of a weird thing to do, especially if you're trying to hit a very specific threshold. In our second visit, this is the one where we actually did the experiment. So for this, we placed our near sensors on the patellar tendon and the vastus lateralis. We made sure we had good placement using ultrasound in the locations we identified in the day prior. We then recorded continuous NIRS throughout the testing session. They did a warm up on a cycle and submaximal knee extensions, and they then had a 20-minute washout before doing their first set of exercise. They did 3 different exercises with 3 different loads. It was all isometric knee extension, but it's just the 3 different loads, 25, 50, and 75% maximum. And these were randomized and counterbalanced. So one person would do 25 first, 50 second, 75 next, and then another person might do 75, 25, 50, and we randomize and counterbalance that using a counterbalance table. They did 8 reps for each set. There were 5 seconds on, 5 seconds off, and we monitored tissue oxygenation throughout to make sure that they recovered within that window. And they had 20 minutes between each load so that we could effectively wash out the previous set. I mentioned that NIRS a few times. Near-infrared spectroscopy is the main way we're looking at the microvascular function of the tendon. So how NIRS works very, very quickly is we are really looking at the absorption of near-infrared light underneath the skin. So we have these different emitters at 4 different lengths and a receiver outside. And from there, we're measuring the amount of absorption of light that's happening. We know that that really the main thing that's going to be changing on the tissue that can absorb light is going to be the blood that's coming through, or particularly the hemoglobin. However, the wavelength that that's absorbed is going to differ between oxygenated and deoxygenated hemoglobin. So oxygenated blood is lighter, as you might know, than deoxygenated blood. That's why our venous blood is always of a darker hue than our arterial blood. And the NIRS system can pick this up, and we can measure our oxygenated hemoglobin, our deoxygenated hemoglobin, use these to calculate total hemoglobin. And then we look at the ratio of oxygenated hemoglobin to total hemoglobin to get our STO2, or our tissue oxygenation. And this does allow us to see how our body responds to stress, because it provides insight into physiological response. But these are relative changes, so we don't have a direct absolute value. We're just looking at the changes happening to our intervention. This is what these signals look like during an exercise and afterwards. So you can see at rest, we have so if you look at the top left, at rest, we have these stable oxygen signals. The dark is the muscle, the light is the tendon. We then do our 8 contractions. With each contraction, you essentially shunt the blood out of the tendon, and then you have this reperfusion in between. So this is how, instead of doing sustained isometrics, these repetitive ones do actually allow blood to reperfuse at higher rates between contractions. And then afterwards, you'll see that this hyperemic response, where you'll have an elevated total blood flow at the bottom left, an oxygenated blood flow at the top. And then this can lead to increased tissue oxygenation, or STO2. And this is well studied in the muscle, a little less studied in the tendon. And this is actually data from our study, but we're using it to show what a typical response would look like. Data is presented as means and standard deviations. We compared the minimum and maximum during exercise just to get a gauge of the physiological stress. This was done with the repeated measures ANOVA. We then, our primary analysis was looking at post-exercise response. So this is our hyperemic response we've been talking about in STO2, total hemoglobin, and oxygenated hemoglobin. We looked at these using a 3x6, or load by time, mixed model MANOVA with Bonferroni post hoc. And 12 participants were needed so that we could test for a moderate effect size for the study. And we had 13, so we were adequately powered. So we did find that the higher loads were slightly more physiologically stressful. Looking at the decrease in STO2 during exercise, that we had a larger drop in our tissue oxygenation during the sets of exercise. But that was the only thing that we saw differ between exercises. This does make sense, because if you think of what we're doing, it's 8 reps at different intensities. So we matched our time under tension, but the 75%, we had essentially 3 times the work of what you had at the 25%. Work's not technically the right word, because there is no displacement, but the physiological work was 3-fold larger in the 75 than the 25%, and 50% larger between the 50 and the 75%. As for our primary outcomes, we didn't find any differences in tissue oxygenation, or STO2, between loads. There were no significant differences. We did see that within the first 2 minutes, or within the first minute, we had this drop off in STO2 that was happening from the exercise. By the minute 2, this was recovered, and by 3 and onwards, we had our effect of a hyperemic response in our moderate loading conditions. But there was no significant difference between conditions here. More importantly, what we our primary finding here was we did see a difference in our total hemoglobin, our measure of blood flow, and our hemoglobin, oxygenated hemoglobin, which is showing us what the new blood coming into the muscle, or excuse me, into the tendon, how much of that did come in. And what we saw is that overall blood flow and new blood flow, or oxygenated blood flow, were significantly greater in the 50 and the 75% conditions than the 25% condition. And that, however, there was no difference between the 50% and the 75%, and that as we went further out from the exercise, that these differences increased. So in summary, we found that exercise induced an acute hyperemic response that resulted in a significant increase in total hemoglobin and oxygenated hemoglobin of the patellar tendon. However, this was observed with moderate and heavy loading, 50 and 75% loads, but not at the 25% condition. We also saw that increasing loads from 50 to 75%, unlike different from what we hypothesized, did not enhance this response, despite the greater work being performed with the heavier load. And just for reference, if you aren't used to training at percents of loads or percents of max, 75% load is we call it a heavy load, but this is what you'd be seeing if you're doing something like a 10 rep max on a leg extension. A 50% load is more a load you could lift around 20 to 25 times, probably closer to 20. And when you get to 25% load, now you're doing maybe 40, 50 reps until you're fatigued. So that we did need to get at least moderate loading, at least around that 15, 20 rep max load before we actually saw that we were able to facilitate this post-exercise hyperemic response. So in conclusion, we observed a threshold of loading somewhere between 25 and 50% of MBIC was required to elicit our increases in both total and oxygenated hemoglobin, but no additional benefits were derived from adding load beyond this point. As for potential applications for individuals at risk for developing patellar tendinopathy, non-fatiguing resistance training with at least moderate loads may help promote tendon health and tendon healing. An adaptation through increased blood flow and oxygenation that is sustained for some time after the cessation of the resistance exercise. However, the study definitely had a number of limitations. This was done in healthy individuals, relatively small sample size. There were some technological challenges, like we did observe skin blood flow in addition to tendon blood flow. We think we excluded for this, and we've repeated this since with sensors that selectively measure the tendon blood flow. So we don't think this is going to directly affect these results. As for what we're doing in the lab now, we have two ongoing studies on this topic, looking at how this hyperemic response may be able to identify pre-tendinopathic long-distance runners. And we're trying to match these to abnormal ultrasound imaging in high volume long-distance runners. We just finished subject 41 on this study, so it's going to be a bigger trial. And from here, we found some sex differences in tendon hyperemic response, with males having a slightly better response than females. We're still looking to see what the potential applications are of this. And we do have a study where we're looking at these responses in older adults, and we're going to try to compare them to these tendinopathic, these healthy runners. And where we're really hoping to go from here is we're hoping to use this as we have 2 grants in review right now, hoping to look at this using this post-exercise hyperemic response as something we can use to determine a tendon's readiness for loading. We're hoping to institute in basketball players here at UConn because patellar tendinopathy is a huge issue in these jumping athletes. And if you could just put one of these sensors on, look at how someone responds to their warm up on a squat or a leg extension or a leg press, then potentially we can use this as a screening screening measure to say, hey, this tendon is going to have an abnormal response to loading. Let's give this person some additional rest, or send them to the trainers instead of having them do their normal workout today. And we also are hoping to repeat these studies in tendinopathic individuals so that we can start identifying how these different therapeutic interventions may respond differently in individuals with tendinopathy. That's everything I have. I want to thank all the participants. This is a picture of our lab from the spring. This study was led by Ryan, and the follow-ups by Jorik and Alex. I'd like to thank all the collaborators, and I'm happy to answer any questions you might have.
I have a quick question for you.
Yeah.
In athletes, I know like you're talking about, and at UConn, obviously basketball is prominent. But even in all Division I athletes, with their regimen of working out, 3 to 5 times a week and being in the weight room, and tendonitis increasing or tendinopathy increasing with increasing exercise, I'm just wondering if you think that incorporating like the prehab exercises like banded TKEs and incorporating, deload weeks contributes to less tendinopathy, or what are your kind of thoughts on that?
Yeah, so tendons have this minimal essential strain needed for adaptation. So a lot of the times we deload too much, and we do see that with all injuries that once you deload more than about 20%, you see a similar increase in injury rate that is you'd see if you increase load by 20%. So giving some of these active recoveries, we do start to see that you might not actually be stimulating the tendon properly. Volume is usually a better lever to pull than intensity too hard. So maintaining that intensity but doing it less volume is something that you can usually kind of stimulate a little bit more. Here at UConn, we actually do a lot of reactive loading with our basketball players. So what we'll do is we'll have them come in and they'll do something like a explosive mid-thigh pull. We'll measure the power off that mid-thigh pull with the females, it's usually a 40 kilo. So it's something that's heavy, but not that heavy. And we look at that power. If they don't have a high power output, we give them kind of the meathead workout that doesn't need that quality. And we just let them focus a little more on volume, or we actually even sometimes give them the day off. So that's one of the ways that we kind of handle that. But yeah, the hard thing is getting them to rest. Like some people, you just need to make them rest. But yeah, having them rest too much then becomes an issue too.
And then I guess as another question, a lot of athletes do like contrast, warm bath, hot ice, what are your opinions on icing, understanding that icing is gonna decrease blood supply to the area?
Yeah, so the heat will increase blood supply, ice will decrease. That does actually get through the tendon blood barrier for the heat, so that's kind of a good thing. Um, Icing itself, we typically try to avoid using as a routine lever or routine modality because it is linked to blunted adaptations to training. I did a study looking at blunted testosterone response, but Peak and others have done uh, better studies on this, actually looking at blunted adaptations after longer interventions with routine icing. So we typically use icing um, more as a way of stimulating recovery when we aren't focused on adaptation. So if you have an extra game coming up, you want to make sure you're ready, go for it. We're talking about blunting adaptations by like 8 to 12%, not nothing, but also it's better that you're recovered for that game than it is that you're getting that little bit more adaptation than you got out of that one workout, but not doing it on a routine basis. I'm really keen on contrast therapy to as something that may prevent some of those detrimental long-term adaptations. For cold water immersion, our study was kind of focused on testosterone and men because, as silly as it sounds, we're dipping the testicles in ice water, and testosterone is released from the testicles in males. So um, we wanted to continue that research and see if the same thing was observed in females, because we don't know, because they don't have, the dartos that physically restricts blood flow to the testes, um, uh, and we were hoping that contrast would potentially be something that where you didn't have a decrease in temperature to the extreme that you see that blunted response. But the company that was funding that research stopped funding it during COVID. So I want to pick that up, but I need a lot of labor to be able to do that.
I have a quick question.
Mhm.
So, in your paper, you mentioned that some non-surgical techniques haven't worked in the past for tendinopathy treatments. Can you give like some examples of treatments that didn't work?
So not worked. It that was really coming off of the most recent meta-analysis. So it just really, there weren't enough studies to find that the effect size was reached. Um, Pretty much everything is under debate other than resistance training. Um, so like something like the glycerin. That's something that I actually think may help people who have this abnormal vascular response, but they wouldn't. It typically doesn't help everyone with tendinopathy. You could have tendinopathy occurring from, hypercoic regions, and increasing blood flow. If you have a disrupted tendon and you have these kind of damaged spots from like a chemotaxic response, or it's just disrupted fibrils, adding blood flow there, you're not at that proliferation stage yet, so it's not going to be effective. um, so that's one that's the research isn't super great on. Corticosteroids don't help. Massage, as much as we want that to help, but actually, physical manipulation of the tendon and massage, I don't think the research is showing is super effective. But things like shockwave is when I think the needling stuff was pretty promising at this point. But I at a conference a couple weeks ago at the American College of Sports Medicine, one of the tendon researchers said that it's not looking promising for needling right now. But I haven't read that. Yeah, so I haven't looked at this in a while. So I gave you the the diplomatic answer of I don't remember. And you should check it out. But at that point, there were a couple that were less, and some of these I think there's just not enough effect size. It's really hard to study. There's one study on some of these interventions, and the meta-analyses that come out, there's more meta-analyses than clinical trials on these, and the same couple studies are being presented over and over again.
So I have a question.
Mhm.
Um, what are the main differences between like an open chain exercise, like the knee extension for like isometric rehab on patellar tendon, compared to like a closed chain exercise, like a single leg lunge and holding that for patellar rehab?
Um, so I'm for the tendon. The tendon's kind of dumb, that it responds to the loading that's being introduced. One of the differences you'll see is the total amount of strain that happens, based on what the starting muscle length is. So if you're doing a leg extension, you actually start with the muscle in a longer position, which means the tendon actually goes through a little less lengthening and shortening, relative to the joint position. Um, Whereas if you're doing something like a squat, you actually start in a shorter position because you start with that leg fully extended and slightly contract before you go through. So there may be some differences in there, but from a force standpoint, uh, the tendon's just feeling the force, and that's why eccentric, isometric don't really matter as much for just pure mechanotransduction, tendon signaling. But some of these vascular things, I think, do matter more on isometric. If you have an isometric contraction, you're not getting any blood flow in. Like you're tensing up that muscle. The pressure is too high to allow blood flow to get into that muscle. That's why if you do like a grip exercise where you just hold it for a long period of time, you'll feel the burning even though you're not fatigued. It's just you don't have blood flow in there. You're feeling that metabolic acidosis that's just occurring from lack of blood flow. You release for a second, hey, you're recovered within a few seconds. The other changes we see between open and closed kinetic chain, the contribution of the different heads of the quadricep do differ. So the rectus femoris will be let's see. The rectus femoris is more active during a knee extension than during a squat because it's biarticular. It crosses over the hip. So when you're doing a squat, it's actually lengthening at the hip while it's shortening at the knee. So it's kind of going through this concurrent movement versus the normal lengthening and shortening that you'd see if you're holding that in position for a knee extension. Our research has found that you activate different parts of the muscle even, so we can actually change the shape of a muscle by doing a leg extension versus a squat. That was one of my favorite studies a few years back, that we had people do one exercise, leg extensions on one leg and squats on the other leg, and we actually shifted the center of mass distally by about 2.5 centimeters by doing the leg extensions, because you actually activate more of the distal portion of the quadricep. So that's one of the reasons we tell sprinters not to do too many leg extensions, because having that distal that distal muscle mass slows the swinging of the leg by increasing the moment of inertia. And even in like world-class sprinters, like you actually will see that they usually have these funnel-shaped thighs, comparing like sub 11 and sub 10.5 100-meter dash sprinters, like some of the world elites. Sorry, I went off on a bit of a tangent, but there are differences. For the tendon, I don't actually know. It's kind of a dumb tissue, but I wouldn't be surprised if you see more proximal shear on the proximal shear on the knee extension, and that may cause some localized adaptations around around the distal pole of the patella, but that would just be a hypothesis. And I only, going into these studies, I'm like 1 in 3. So like, even this study I presented, I thought we'd see a graduative response. We saw a capped response at 50%. So just because I have a hypothesis doesn't mean it's going to be right, which makes research fun.
Thank you.
All right. Well, thank you, Dr. Earp. I appreciate you taking the time to present your research and answer our follow-up questions. If anyone else has any questions, can they reach out to you, or is there a way is that okay?
Yeah. Go ahead and feel free to give my email address. I'm happy to answer any questions. And yeah, thanks so much for having me.
Perfect. Thank you. And thank you everyone for joining, and have a good rest of your evening.